All right, Chris. Today we're flipping the script. How you doing?
I'm great, man. How are you?
Doing well. I had about 4 slices of cake as part of my breakfast, so
Oh my God.
feeling pretty good.
What type of cake?
I bought a cake last night that was like 4 different types of cake. So I had 1 slice of each one: red velvet, like double chocolate, like caramel and butterscotch, and then carrot cake. So I know you went to the gym already this morning, so I'm not feeling quite as accomplished as you.
What out of those four was the best? What was the worst?
Normally I like red velvet, like red velvet's top tier for me.
Hmm.
Carrot cake's definitely up there. Chocolate's usually my least favorite, but just in terms of the quality of the cake, I would say the caramel and like butterscotch one, like just the cake was the moistest out of them. The other
Mm.
ones were like a little bit dry, so they made up for it with packing on the frosting. They try to cover up a not well baked cake.
Where'd you get all the cakes from?
Well, Nicole wanted to get some dinner last night, so we walked to food truck. There's like a lot of places that we can walk near us, and she got some stuff from a food truck. So I was feeling a little bit left out. There's a grocery store next door. So while she was waiting for her food from the food truck, I decided, you know what? I'm going to go into this grocery store, see what I can find. I came back out with a big cake of 4 different flavors.
Have you ever
Um,
been to Milk Bar? Is there a Milk Bar in LA? Wasn't it started in LA?
yeah,
What are
yeah.
your thoughts?
Anything that's cookies, ice cream, cake, I'm going to eat it. I'm going to like it.
Yeah,
If you ever come down to LA, I'll give you the full tour.
perfect. Well, I'm lactose intolerant, but I will just take it on uh, if it's worth it.
There's a really good vegan donut spot. It's not near where we live now. I don't remember the name of it. Where we used to live, this was like 7, 8 years ago. It was near us there. And I think the first few times we went, I don't even know if we realized it was vegan.
Mm,
And it was incredible. So, I mean, they have
I love
everything.
that.
You can find anything that you want here.
Solid.
Um, okay, more important topic. So today we're talking about, we're going to discuss the trials and tribulations of a new grad physical therapist. I know you've been practicing for over a year now, so congratulations on that. Before we get into the discussion, why don't you remind the listeners what it is that you do? What setting are you in? What's your role? Kind of give us an idea of your day to day practice.
Surely. I am a physical therapist in Gig Harbor, Washington. I actually graduated a little under a year ago. Graduated or started practice. So I graduated in May in Texas and then moved up and started in late August, early September. So a little under a year, but I work at a multidisciplinary sports med clinic where we have multiple departments within the clinic. So we have a physical therapy department, sports chiropractic, orthopedic surgeon and his PA, massage therapy, and athletic trainers. So I'm there full time Monday through Thursday, 410s, and then remotely Friday on the weekends with E3. So I've been there since I graduated, and it's been phenomenal.
So, since starting, what's been the most challenging aspect of clinical practice?
There's a few things, and I felt this very early on and still feel it with certain scenarios, but a lot of these patients, I noticed it with high schoolers where the first ACL reconstruction would come in and it'd be the patient and their parents, and they would ask, "What is your experience with these in the past? What would you have us expect moving forward?" And really just them trying to get a read on what have I seen from a results or from an outcomes perspective. And that felt very mm, like tough to navigate those conversations when they were literally my first patient that I've had an ACL experience with outside of clinical rotations. So trying to navigate those conversations where I don't want to come across as I'm completely uncertain about the situation, but I also don't want to completely lie and have this sense of, oh, I've seen hundreds or dozens of these, this is going to be okay. So I would largely and still largely base my discussions and expectations based off of more research oriented discussions and what we know from the literature on kind of average timelines, what our priorities are, and other clinicians in the clinic that I trust, and hankering conversations to these are within the clinic. This has been our experience with other ACLs or other XYZ. So it feels tough because I don't have that experience and I don't want to lie, but I also know that they're looking for reassurance and confidence, and I want to portray that. So trying to balance that has been pretty tough. So that was one of the bigger challenges. Probably the second one has been this uncertainty of, with these longer rehabs like an ACL, knowing where to go next and this step-by-step process. Obviously it looks clear cut in the research, and these are some of these like objective markers to go from here to there, but the day-to-day or the week-to-week fluctuations of, do we pull back today, do we kind of stay where we are, what are these next hurdles that we need to go through, and patients that are gung-ho on wanting to return to run or return to practice, and trying to navigate those conversations, and my uncertainty of, is this too early? I haven't had experience with these populations in the past, so I can't really create a like filter in my head of what is too soon or what is kind of normal within these normal ranges. So those two have probably been the biggest challenges of the conversations with patients and parents, trying to figure out how to navigate that without extreme uncertainty, and also not this like overconfidence that I just don't have that experience. And then the kind of day-to-day or week-to-week, where do I go from here if I haven't seen these populations before? What are the next steps? It's probably those two.
Let's delve into both a little bit more, and they both sound to stem from inexperience at no fault of your own. With the first one, how often do patients ask you, how long have you been practicing? How long have you been working here?
It felt like it was more common early on, but maybe that was either a coincidence or I just picked up on it more. But there's normally two questions. One, they'll ask, how long have you been practicing, or when did you graduate? Or it'll be more specific to, how many of ACLs have you seen? How many total knee replacements, etc. So it's hard to give a number. I would say early on, it felt more common because they knew I just moved. And I would say I just moved to the area. And so they would ask, how long have I been in practice? But right now, it feels less common. I would say maybe every few weeks or once a month, if I have an eval, a patient may ask, how many total knee replacements have you seen? But it's definitely not a day-to-day or a weekly thing at this point.
The first time you heard that question, how many total knee replacements have you seen? How did you respond, knowing that as a licensed physical therapist, it was actually going to be your first?
I think I said, within the time of graduating, this is my first full case. On clinical rotations, I've seen multiple, and I've interacted with multiple coworkers and talked through them about their cases. So I would be honest, but I would also say, fortunately, I had a 3-year doctorate and I had experience there and learned quite a bit about it. And I'm also having this shared discussion with coworkers. And to that point, I've done that a lot with some of these youth athletes with ACL rehab, where I'm thinking of one guy in particular, and I would be very upfront with him. I said, there's a coworker that I trust and value his perspective a ton, and he's seen more than I have. I want to hear his thoughts before I give you a full answer to XYZ question, whatever he had, or my uncertainty of kind of what our next steps are, I would say, hey, I'm going to talk to this individual just to hear his thoughts, and then we'll reconvene next session. And I think he appreciated that, of me just being transparent, of we want to get multiple opinions. And even to that point, this is less not less serious, but like if we have a patient come in, a lot of times we'll have multiple therapists come and like recheck each other's range of motion or recheck swelling and effusion. So it's always this kind of like interplay between providers where patients are comfortable and familiar with us, like almost checking each other each day.
As you know, last month is when the next cohort of physical therapists just graduated. So they're probably studying if they haven't already taken their board exam, and they're going to take their board exam. And so they're going to be in your shoes pretty soon. Is that what you would recommend in terms, like, I posed that question to you as if I were a patient. It really is your first time seeing the total knee replacement as a practicing clinician. Is that what you would recommend to them, is answering it how you answered it? Or now that you've reflected more, maybe you would answer it a little bit differently? What do you think?
That's tough. I would say each person is probably going to feel more comfortable answering in one way or another. I would say I'd rather be honest, but give some caveats than completely lie. So to me, that seems like the clearest option of, I did just graduate. However, I had training in this. I've seen patients in rotations. Fortunately, we're in a clinic that is a provider, so we're going to work through this. And this is something I feel comfortable walking you through. And these are, from a research perspective, this is kind of what we know are the steps that we need to go through. So short answer, yes, I would recommend that. What
And
are your thoughts?
Yeah, I was gonna say, I've been in your shoes, and I've mentored physical therapy residents for quite some time now. And for anybody unfamiliar, a residency as a physical therapist is an optional thing. You're already a practicing clinician. A minority of physical therapists go on to do this residency. And within most residencies, you get direct mentored hours. So when I would mentor residents, I would kind of give them the option of how they would want to introduce me. So some are very clear with every patient that they see. I'm a resident. I'm doing this for the next year. It involves teaching and research and this, and that. But I am a practicing clinician. But in terms of how they would introduce me, I'd give them the option of, you could either say, I'm your mentor. And for some, I could understand how that might make them think that the patient thinks that they are, less capable of managing their rehab. Like, if you have a mentor here, why would I not just see your mentor or someone like your mentor? Right. So I would give them the option of, introduce me as your mentor if you want, or just say, this is my colleague. And I could make the joke of, if they ask, like, well, why are you here? And I can make the joke of, oh, you're in luck today. You get, 2 physical therapists for the price of 1. And, patients are okay with that. So I do think that it's going to vary. And I don't know if I have the right answer. Same thing. I was a resident. So I did do a residency at one point, and I did have those mentors every single week, 4 hours a week. You try to schedule evaluations. So new patients, at least, 1 to 2 of those hours. And you'd have to decide, am I introducing this person as my mentor, as my colleague? And the way that my mentors did it is that we would take a subjective history and then say, we'll be right back. We step outside the door, we discuss the case. I'd have to rattle off, my differential diagnosis, what I'm going to do in the objective examination within a minute. It'd be fast. And then we go back in there, and then I do, my assessment, step back out. Okay, now what am I thinking? What's my management going to be? And then step back in. So the person probably had an idea that I was discussing this case with this person who was my, I don't know if you would want to describe it as like a superior, So it does leave you in a tricky situation.
Hmm.
In terms of the uncertainty that you described, how have you been managing that?
The best I can. I don't know if that ever goes away. Like I know therapists in their 30s, 40s, 50s that still acknowledge that inherent uncertainty. And I feel lucky that knowing those individuals that I look up to as mentors that still feel very uncertain of just the realities of working with humans and some of these conditions, that that's probably never going to go away. But some of the uncertainty of the, oh, I just don't have experience, I manage that by realizing that it's only going to get better the longer I do this. So it's just like you kind of have to, I've just sat with it and realized it's not the most comfortable, but the further out I am, I'm only going to get more experience and more reps and see more of these. So fortunately over the past year, it's progressively gotten better with the just the uncertainty of what I should be expecting or seeing with specific cases, but the uncertainty from a meta perspective of providing care to patients and what I'm doing, is this moving the needle, and just the inherent uncertainty of research and working with people, that I think will probably stay forever.
Do you think half the battle is acknowledging and accepting at least some level of uncertainty with everything that you do, regardless of your experience?
Yes. And I think I was very lucky during rotations to have multiple mentors that did a great job, that I would see express that to patients. Where I can think of two examples, or two clinicians, Mike Amato in Boston PT and Wellness, and then John Hodges in Nevada at FPT. Both of the times, either during evaluations or day to day, it was very comfortable for them to have almost like a shoulder shrug. If a patient asked them something, then they truly didn't know, because we don't know, from maybe the evidence isn't there yet, or they just don't have a good answer. And it was like, this, it's not a big deal if we don't know the answer. And it almost like took a weight off my shoulders of, they weren't trying to just stumble through making something up just to like provide a clear answer to the patients. So having that as an anchor in grad school going into clinical work helped me a ton, where a patient, if they ask me something and I don't know, I feel now comfortable saying, I'm not really sure, or we don't know. And I think that is half the battle. So to me, it feels almost, I don't know if the word's comforting, but just now acknowledging it, it provides some relief on my end of, well, I don't always have to provide an answer if I'm not sure. And sometimes I'm truly not sure because going back to it, I just haven't had that experience, or I'm not sure because like the literature, we're unsure of XYZ.
I can definitely see the internal struggle with students and new grads because I worked with clinicians, I interacted with clinicians and spoke to clinicians and viewed other clinicians online that, at least outwardly, expressed or demonstrated zero uncertainty, meaning that they were always certain. The person has this SIJ discomfort. You do this treatment, followed by this treatment, followed by this treatment, and the person is going to get better 100% of the time. This person presents with this, you'd follow this treatment algorithm again, and they're going to get better. And if they don't for some reason, it's no fault of your own. It's on the patient. I don't know if you've experienced that or seen that as well. Maybe less so with the clinicians that you're interacting with, which is great, but perhaps from a social media perspective, where people seem to have all the answers.
Yes, that, yeah, I feel like runs rampant in social media. I noticed that with professors. I felt like a lot of times they would just try to force an answer, even though it became obvious that they were truly uncertain. And this I was actually listening to a podcast yesterday. I'm not sure how to pronounce his last name. I think it's John Lehner. He's a physician in the UK, and he's written multiple opinions and editorials, I think in the BMJ and other places, but he has multiple books. And I just ordered one, How Not to Be a Doctor. And he was on another physio podcast, and they were chatting about that book in particular. And I think there was a chapter, I'm blanking on the title, but it was essentially like the value of not like over explaining as a healthcare provider, of just trying to always give the patient all the information to make it seem like you know all the things. But the more you give, either the more they become confused, or more it becomes apparent that you truly don't know what you're saying. You're just trying to sound smart. So that I'm trying to be aware of how much information do I provide that is valuable to the patient and that I can feel somewhat confident explaining. And then when I feel like I'm over explaining, is it because I'm just inherently self-conscious about X thing and I'm just trying to make up for it by talking?
As you mentioned with your professors, school, university, unfortunately, doesn't necessarily often teach you very well how to navigate the uncertainty, because you take a written test and you're either choosing a right answer or a wrong answer most of the time. There's no gray area when the answers are A, B, C, or D, and only A is the correct answer. And similarly, when you're doing like a practical exam, for once again anybody who doesn't know, where you might be acting as a physical therapist and your teacher is acting as a patient, or one of your classmates is acting as a patient, you have to give the correct answer, or the most correct answer. You're not allowed to say, I don't know, because if you don't know, then you get a worse grade. And I try to kind of embrace this uncertainty when I taught. So I've taken a step back from teaching, but I taught across multiple courses for 4 years. And up front, I would tell people that I would not necessarily have all the answers. And some students would sometimes get frustrated, right? Because maybe the other professors would always have an answer. But if I got asked something I didn't know, I might say that, but I would always follow it up with, if I can find the answer, I will find it for you. Meaning that, like, I'll go dig through the research, I'll go ask other people, and I still might not be able to find that answer. But then I would also try to provide a safe space for students to provide uncertain answers as well, especially in the third year. We do more case discussions. And so allowing them to explore those uncertainties, I think, was helpful. And at least I hope so, going into clinical practice and understanding that they might have a different perspective than me. They might have a different perspective than their classmate. And there's not always going to be a black and white, wrong or right answer. So I definitely think that's probably one of the biggest challenges as a student, as a new grad, as a practicing clinician, is just accepting or acknowledging, accepting, and tolerating the uncertainty that is inevitable. It'll always be inevitable. I think the more you embrace it, though, hopefully the less heavy it'll feel. That the weight of that uncertainty hopefully just won't feel as heavy.
To that point, what I have noticed in this clinic in particular, because it is multidisciplinary, patients may have a consult with our ortho, and they may provide, or the orthopedic team, and they may provide a much more pathoanatomical answer and say that this is because of this. Like, your shoulder pain is because of this slap tear, or because you have, a hip FAI, or whatever it is. And a lot of times my understanding from the patient is that was expressed as like this certainty of this is the thing. And so how do I not invalidate them and this conversation they've had with someone in the exact same clinic? And that's also from a hierarchical, how a lot of patients see it, like this is the physician. It's more like an explanation or exploration of okay, what were your thoughts on that conversation? Do you agree? Do you disagree? Do you have questions about what they showed you on imaging? What is your understanding of, yes, this is apparent on your imaging? What are your understandings of like how this can be managed besides surgery? And so trying to manage the uncertainty of, to them, where something was portrayed as more certain than it might be, that has also been a good challenge, but sometimes a tough challenge to navigate what a provider is saying in the same clinic. That's like not inherently wrong. Like, okay, yes, this was on imaging, but how do we pull back and view other contributors to your pain experience or some of this loss of function, and maybe create a little bit more gray and uncertainty, or just accept that there's a lot of factors here as opposed to just the anatomy.
I think that's a good perspective. It's almost this aspect of motivational interviewing where maybe you help the patient appreciate some of the uncertainty. Like you said, you might ask them, what do you think of that explanation? What do you think is going on with your shoulder? What do you think is going to make it better? And they might say, I don't know. I've heard exercise is really good. I heard that injections are really good. And I heard that maybe surgery can work. What do you think? And now that gives you the opportunity to understand that they do have uncertainty with which one of these treatments is going to work. And based on your knowledge, your expertise, your understanding of the literature, you can present those options and say, well, actually, we've seen exercise and surgery have similar outcomes. So it makes sense to start with the exercise, strategy. Um, so yeah, sometimes just if the patient asks you a question, it's totally okay sometimes to ask questions back before providing an answer as you gather your thoughts, as you gather more information. Now it's not this endless. They ask you a question, you ask them a question, and then you just never answer any of their questions. But I think sometimes having a better understanding of that perspective allows you to present that uncertainty in a more packaged, neatly packaged way, I suppose.
Totally.
So, okay. So we talked about two of the most challenging things for you so far. What do you think's been your biggest win?
Yeah, you sent this question, and that was actually the hardest thing to think of. My immediate thought, and maybe if I reflect more on it, better things will come, but my immediate thought is not re-rupturing someone's like ACL, or they had surgery and immediately I just completely fucked something up. That, I guess, like has been a big win, that I haven't done major damage to the system with someone. But I think another big win, because that's more just like fear driven, but a big win is actually finding a clinic as a new grad that I feel happy and comfortable and like I can grow in. And so I don't know if you were hoping for an answer of like biggest clinical win with specific patients and outcomes, but I think more so as a new grad, what I've seen a lot from my classmates and from others, it's just this unfortunate reality where I'm not even a year in, and I know multiple people that have already hopped 1, 2, 3 jobs, not even within 12 months of graduation. And to me, I talk with my coworker or coworkers a lot about this, of like, I'm just so grateful that I'm in this setting that I know is rare, especially in like the sports medicine and orthopedic settings, where they're typically these mills and you get burnt out in a month or 6 months or a year. So I would say the biggest win is feeling like I have the autonomy and the time and the resources to practice and grow and learn as a new grad, where I could very much be in a setting and I don't have those opportunities and affordances. So that's probably be the biggest win.
Was it luck?
No, no, it definitely wasn't luck. It was, and this may go to some of the later questions, but being the guy that talked to all the people and networking and having multiple options and opportunities and having the ability to choose multiple options or think through multiple options. So no, it wasn't this like luck, it just happened. It was this long drawn out thought process and sitting down thinking, what are my priorities as a new grad, as outside of work, what do I value, and what environment, what city, what things do I want access to, but then within the clinic and career growth, what do I want access to? So yeah, I would say I put myself in the position to be where I'm at for sure.
Making the right choices, probably having a certain mindset, I imagine helped with that.
Mm-hmm. Yep.
Makes sense. I think it's a question that people should ask themselves, though. Like whether it is about finding the right job, having a success with the patient, asking about those wins, because just as a species, we are so drawn to negative things. Like I think I've probably brought this up on the podcast before, but people could leave 50 nice comments on a YouTube video, and then there's one just really mean one, and like you forget all the nice comments because of that one mean, nasty comment or whatever it may be. And rather than saying, you know what, these are the things I want to avoid because I've had a bad experience with them, which is totally valid. We all do it. We all should do it. Obviously, you want to try to stay away from things that are making you unhappy or unfulfilling, but also trying to gravitate towards the things that are making you happy. And so, rather than just thinking about, yeah, what are the negative aspects about this job or my clinical experience, or even, we think about like the patient that maybe we did have a bad experience with. Like maybe you did have somebody who re-ruptured their reconstructed ACL, and that's all you can think about. And then you totally ignore the other 100 patients in the past month that you've helped, but the only one that on your mind is that re-rupture. And you want to reflect on that and learn from that and become a better clinician because of that, but don't forget some of your successes, because hopefully thinking about those successes, reflecting on the successes can keep you afloat during some of those tough times, because there's always going to be ups and downs in life and your career.
Yeah, to the failure point I didn't mention, but my assumption and my goal after school was to go straight into residency, and I was dead set on that as early as my first year. I had one dream residency in mind, but I applied to 3 and I didn't get into any of the 3, and it was like, what do I do now? Where my entire mindset was, I want more education, I want more mentorship, I want to stay within a health system, a hospital system. And when that doesn't happen, what are the things that I wanted out of that experience that I can get in not in a residency? So I'm sure there are multiple students that have either a similar experience that they're dealing with right now, or they're going through the residency process or application process and deciding, okay, if I don't get in, it's not at the end of the world. What was I hoping for from that experience that I can search for within other jobs? And for me, it was, I wanted to be in like a multidisciplinary setting. I wanted one-on-one care. I wanted mentorship. I wanted resources to equipment and access to testing items that I felt was necessary. So that was still the goal for a clinic. And I think students and new grads should keep that in mind, of searching for like the valuable things as opposed to just like, I want to do this because I'm assuming that's the next step to go into residency. And I think I would have had a phenomenal experience if I were to get in, but it's just reshaping expectations and goals if the things don't turn out how you want them to. And that doesn't have to be just for residency, but that was my particular case.
I want to say that I wasn't intending to apply to residencies, but my current wife, Nicole, my only wife, Nicole, girlfriend at the time, she was wanting to apply to sports residencies. So she applied to the USC sports residency. So I said, okay, I'll apply to the ortho sports residency. And I got in and she didn't. And along the way, she's had difficulties and hardships and was unsure of herself. And hopefully she's okay with me talking about this because she's kind of spoken about it publicly, but she kept at it. She kept saying that, I want to work in professional sports and I want to be up there and this is what I do. And she jumped at every opportunity. And now she's the lead physical therapist for Red Bull in North America, right? And so that was without the sports residency. So the sports residency might have offered her some of the opportunities that she had to go seek out on her own, but she made sure to get those opportunities, to get those connections, by fighting for them. So, like you said, I, yeah, if there's, if there's a will, there's a way. Hopefully you can make things happen if you want them to happen.
What are your thoughts since you went through residency and you're a mentor? You've been a mentor for that residency. Of would you recommend students go through it, or do you think that should be a standard part of the PT process?
I think we need to have a several hour podcast episode for that. It's difficult. It depends on what you want to do. Like I said, I ended up teaching for many years. If I didn't do the residency at that university, I probably wouldn't have been offered a teaching position. Like most or a lot of the faculty there have gone through the program or they've become residents, right? If I wanted to do research, I did research in the residency. It could have set me up to do research afterward. So it definitely gave me a lot of opportunities if I wanted to go down that route. I made great connections. I'm friends with top researchers in the field. So for sure, it gave me some opportunities, but I still think that if you wanted those opportunities, you could probably get them through a different avenue. So going back to patient care, like what lessons have you learned from interacting with patients that you didn't learn in the classroom and you can't learn from a book?
Yeah, I think I learned this. Fortunately, I had this experience prior to PT school doing SNC internships and becoming a personal trainer. The day-to-day conversations with patients of non rehab related things, of how to spend 30, 45, 60 minutes with a patient and make them feel comfortable and listen to and enjoy that interaction and laugh and remember what they did last weekend and what their plans are. I think that there's just no way to teach that in a classroom setting or read it in a book. But I think especially in these orthopedic or sports med settings where you may see patients for weeks, months, this prolonged period of time, there has to be this rapport and relationship built that's probably going to dominate the interaction of these non PT related questions and conversations. So that it's probably been the biggest thing of like how to just interact to another human and ask them questions about their life and not be so serious about their knee for an hour, because then it doesn't make it enjoyable for them most likely, and it makes it just this like serious, overly serious thing. So I would say that's one of the primary things that you're not going to learn in school or in a book, of making patients enjoy the process of coming to PT. And I mean, sometimes it's just going to suck because of the work they have to put in and what goals we need to get to. But there should at least be this like ease of a flow of a conversation and of a rapport throughout the process. Other things, when something doesn't go according to plan, like when shit hits the fan, or if a patient says something that you weren't expecting, I don't think you can really prepare for that from the classroom environment or from a book. I remember I had a woman I think it was our initial follow up, and this was months ago. It's some of the specifics I've lost, but she brought some things up at the initial eval about some beliefs she had, and I probably didn't do the best job navigating those beliefs. I may have like created a little bit too much like dissonance of maybe providing that information she believed was incorrect. And then the next appointment, she comes in and she sits down and she's like, I just want to tell you, I completely disagree with what you told me on the initial consultation. And fortunately, I ended up at that time, I talked with Derek Miles about this, and he said, you built enough of a rapport for that person to come back in and feel trust and confidence to like tell you that. They could have very easily just not shown up. But that moment where it's this like, oh shit, how do I navigate someone just explicitly saying they disagree with what I told them? Things like that, just you just learn it and like stumble through it in real time. So both of those, the first and second things, are pretty much just conversational based, where those don't develop in a book or in school.
Yeah, that's awesome. That patient experience, that the explicit I disagree with you, like that's like Derek said, that shows that you have a level of trust built there, that the patient felt comfortable to say that. We had a communication class in PT school, and so we would have different interactions with classmates and whoever else, and they would be recorded and we'd be graded on those recordings, and we'd have to watch those recordings. And like one of them was, you're sitting at a bus stop and you don't know what's going to happen. So you're sitting at this bus stop and random person sitting next to you, and they have like paid actors, and then this paid actor just tells you, I'm having a really rough day. I just found out I have HIV. And so then you're recorded and you're graded on how you interact with that person. They expect us to be empathetic, caring, compassionate healthcare providers. How do you react to the stranger that you've never met before that tells you about this life-changing diagnosis? And maybe you're the only person they have to talk about this. And like you said, well, first I would say life experience prepares you for clinical experience. The more life experience you have, the better you are at talking to a person on a park bench, probably the better you're going to be at those patient interactions, because you're in your first year, but people are going to tell you about their sexual experiences, maybe abuse, their religious beliefs, their political beliefs, and they're going to be people that you maybe strongly disagree with in your mind, and you have to try to decide, okay, how do I navigate this conversation? Do I want to even try to engage with them here? Do I change the topic? Do I ask more questions? What do I do? And that just, like you said, yeah, you can't learn that in a book or a classroom. But it's always, those are just good experiences to have and reflect on, and you become a better person from them, I think.
Did that communications class, even those were mock kind of fake scenarios, do you appreciate those interactions, or did it feel too like sterile?
I didn't appreciate them. I didn't appreciate the soft the soft stuff in school. So I didn't appreciate the communication class. I didn't appreciate, we had this professor who was always, his favorite word was metacognition. I was talking about metacognition. And, it wasn't until after the fact when I realized that there's more than exercise and manual therapy and, whatever else, that like, oh, like these things are actually at the foundation of what we do. I don't know if I just probably wasn't at the point in my life or career where I was ready to really fully embrace that information. Now that I am, I've had more life experience.
Can I go back to one of the other prior questions you had? I have another thought.
Yeah.
The biggest win. So, and this could have been inserted in one of the other questions, but one thing I've noticed with myself was in grad school, I was very angry, like every day, like with professors and with other classmates and with the curriculum and with the process. And I wasn't in a good like mental headspace for 3 years because of my frustration with the schooling and the rigidity and the lack of conversations and disagreement. So I don't know if that like rings true to you, or if other like students are listening, if they feel that currently. But now I'm in a setting where I'm still surrounded by clinicians where I don't see eye to eye on, and I can easily be like on a daily basis frustrated, but I've tempered my expression outwardly and inwardly of seeing people more as like, okay, I don't see eye to eye on you, but do I need to get this frustrated or emotional about it? And that is, I think, a big win, because if I kept that much like resentment or anger as a new grad with interactions with other providers, it just wouldn't be like healthy. And viewing it as I will never see eye to eye with people, and it's like, how do I develop trust and friendships and growth with these people as humans? And then over time, we maybe like morph both of our views on things. And I think that has been also just a big win with not becoming so overreactionary to things that I disagree on. And I think a big part of that has been like removing myself from social media, because it's been so, I think that it's an easy place to just see this like dogmatic polarization on both sides, and just these quick like clips of, you know, people calling out to other providers. And I think sometimes it's comedic and helpful and rattles the cage, but I think other times it creates this expectancy that we should always like freak out or get mad about something we disagree with.
Yeah, I would say that I probably didn't have that experience in school where I felt like I could raise my hand or go up to a professor and disagree, even if it wasn't a respectful way. And I think it's, helpful as a clinician to have somebody that you can have these kinds of discussions with, and bring it back to what I was mentioning earlier. As somebody who was teaching students, I try to set that expectation very early, that I am okay if you disagree with me. I'm not going to take it personally if you disagree with me. I just want to understand your rationale. Like if you just say you're wrong, I'm going to say, well, why? Like give me a reason as to why you disagree, and then we can have a healthy discussion. And I think, maybe if you had someone like that you could have that discussion with more as a student, if I had that, yeah, it probably would have been better. Maybe if I had a mentor who was like, man, I'm taking this communications class, it seems pointless, I don't understand why I'm doing it. And they go, well, actually, Marc, in a few years, you're really going to understand why that's so helpful. Maybe I would have went back into that class the next day and gone like, oh, okay. Now that I had this discussion with whoever this person is, I can appreciate how this communications class is going to help me. Although we took a class on like genetics and like, whose mother's brother's sister's grandma is this, there's no amount of convincing that was going to be helpful for my career, and it still holds true. I guess we're on the topic, but anything that you did outside of school that you felt better prepared you for this first year?
Yeah, I've alluded to it, I think, in other episodes. In undergrad, I did multiple internships, and that prepared me a ton for interacting just with humans, and then having a relatively strong foundation of strength and conditioning principles and exercise progression, regression, all those things was huge. But from like while I was in school, in grad school, preparing me outside of just the class setting was pretty much talking to like all the people that I wanted to, and just reaching out to students and clinicians and researchers. And I think Sam and I had this conversation in a previous episode of feeling comfortable or just doing the the reaching out was huge. And I think developing relationships while you're in school to set you up for opportunities before you graduate is huge and was huge for me. But then organizations like Clinical Athlete, like having that forum, being able to communicate with students, clinicians, and then that kind of morphing into CalU Plus, or the CalU community, resources with Barlow Medicine, and like mentorship with Derek Miles, information through E3. Like those kind of big three platforms were phenomenal for reaching out and communicating with other students and with just gaining information and having it be a little bit more digestible. Yeah. So the internships in undergrad were huge. Just reaching out to people and talking with as many people as I could, and then finding resources like E3, Barbell Medicine, Clinical Athlete, CalU. Yeah, those were huge. And I'd recommend those to any student interested in the orthopedic MSK sport world.
Yeah, those are great resources. Yeah, just go out and make connections, talk to people, interact with people, send them thoughtful, genuine emails or messages. I've talked about it on the podcast before, but for the residency, prior to even applying, Nicole and I came out to LA to visit. I have like family in the San Diego area and some relatives out here. And I emailed the director. I said, hey, can I meet you in person? Can we talk? Sat in his office, talked for an hour, asked me if I needed a ride. He gave me a ride to where I needed to go. And once I got into the residency, he told me that he had already decided that I was in before he even read my, resume or CV or anything like that because of the conversation that we had. Just emailed him, can I meet with you? I took that initiative to, sit down with him for an hour, and then just, when we're in the car, we're just shooting the shit, talking about whatever. I had another example. Maybe it'll come back to me.
Did you do that a lot before residency? Like when you were at Emory in grad school, did you reach out to a good amount of other students outside of the program or clinicians or researchers?
I didn't. Oh, do you know how Tony and I met?
No.
So Tony, back when he was on social media, right, we were both kind of doing the same thing, like just posting whatever to Instagram, had decent followings for back then. Obviously, there's many more physical therapists with much bigger followings than us on our individual accounts these days. But I think I posted maybe on my story that I was going to go to a course, a continuing education course here in LA, Greg Lehman's course. And Tony messaged me and was like, "Oh, I'm thinking about going to, like, any recommendations of places to stay?" And I didn't know him personally. I've never like talked to him, just like maybe quick comments on his post or like a quick DM here and there. It was never like, "Hey, how you doing? Who are you? What do you like to do?" But I simply said, "Hey, you need a place to stay. You can crash on my couch as long as you're not like a serial killer." And then I had to ask Nicole after the fact. I was like, "Hey, by the way, I preemptively invited this guy who we don't know at all to sleep on our couch. Is that okay?" She was a little taken aback, but luckily Nicole's pretty chill, so she was like, "Sure." And Tony booked the course, crashed on my couch. We became friends, and that was it. Now, I'm not saying that everybody should go and sneak into somebody's DM and offer that they can crash on your couch or ask if you can crash on their couch, but it's just a matter of making those connections and putting yourselves out there. The worst most people can say is no.
True.
Yeah, so I guess social media, how much does it influence what you do?
Now, not a ton. I try to limit it. I'll check it like twice a week. And right now, I would say the biggest thing is accounts I'll follow. If they share papers, I may like get motivation to find research to look at, but from a like utilizing the content as driving my care, it's minimal. I would say it was huge in undergrad when I was just looking into finding people to follow and learn from when I was going down the route of S&C. So finding a ton of strength conditioning coaches and then finding some physical therapists. I think that's initially how I found Quinn Hennick and heard of like Clinical Athlete. So I don't like, now I'm kind of nihilistic about like, especially Instagram, but social media in general. And I think that's probably not like a recommendation for like a broad recommendation, because I think it is extremely valuable. But I just think there's a long-term better approach is meeting and connecting with people potentially through social media and then yeeting out of there and actually developing like human relationships through either in-person interactions or phone calls or Zoom. And it just is a very superficial platform or platforms to like gain deep knowledge and conversation. But from a quick like bits and pieces of information, I think it's great. But from a media perspective, my consumption now is much more strongly oriented towards longer form content, whether it's long YouTube videos. I mean, I literally all the E3 ones, and then podcasts. That's like pretty much the majority of my outside information from like primary research. I would say the downside of social media is, one, just the comparison culture with like other students or providers, and just it put me in like pretty bad headspace. And then the expectation of, I'm not going on this app to like sit down and be in the headspace to digest like something in depth. And so I think the platform itself is oriented towards like quick, like very kind of dopamine hitting things. And to me, like I'd rather just watch dog videos on like Instagram than like this in-depth thing on rehab. So for me right now, it's less of an importance or plays less of a role. But when I was younger, it was very beneficial for just like finding people and then reaching out to them. I think it's a great platform to like get access to humans and their maybe library of information. But then I think the next step is like go beyond that superficial nature of these platforms and create actual human connection.
Yeah, we could easily have this huge philosophical discussion about the use and application of social media content, of asking yourself, why am I going on this app? Why am I spending time here? What could I, what am I not doing by spending time here? But yeah, that makes sense. Something else to say?
Well, I'm curious to hear your thoughts. And I'm obviously like with E3 as a whole, social media is like a huge platform, but is the goal to reorient towards like the longer format videos, articles, etc.? And yourself personally, like where do you see yourself using social media?
So, in terms of the creation of our content, we've definitely geared more toward long form content. It's kind of what inspired the creation of E3 Rehab. Is we were doing all these like quick videos on our own personal pages, and I wasn't providing the value that I wanted to provide. And I thought by providing more long form content, I could do that in a way that maybe other channels weren't quite doing. So with the blogs and the YouTube videos and this podcast, I was hoping that that would be a way to do that. Like I don't like to say I made the video, but I wrote the video for the ACL rehab. That's 30 minutes long. We create it as a collective whole, but I wrote that, and that's a 30-minute free video on ACL rehab, and you can't get that information in an Instagram post or a TikTok post, even in a pod. Like that's going to be very hard to find anywhere, and it's incomplete. You're not going to be able to take your rehab from start to finish by using this video. But my thought is that hopefully it provides value for a lot of people by making content like that. I can't answer every question. I can't individualize it. People still need to see clinicians in person and, consume other information, but the goal was to provide more valuable content. My own personal consumption, I try to minimize it. We kind of split some of the posting of content, and I pretty much tried to post and get off. Otherwise, and I use like a daily checklist type of thing. I'm not always perfect with it. Of like, I want to try to hit this many steps. I've told you that I try not to use my phone the first 2 hours in the morning. I try not to use my phone the last 2 hours of the night. And so that's like on my checklist of things to do. So like one of those is, use social media once per day, meaning log on, I post, maybe I swipe through for a couple minutes and then get off. But then the intention is not to get back on, or on that one time that I am on, not to get sucked in and just swipe for 30 minutes. So that's my own personal consumption. There's not really much on social media that's going to benefit my own practice or life in any significant way. If I'm being honest, that's the stage of life that I'm at right now. Maybe that'll change.
Mm-hmm.
One of the last questions, I've heard some students and new grads say that they have imposter syndrome. Do you ever feel like an imposter? And this kind of goes maybe back to the discussion that we had at the very beginning in terms of the uncertainty and the clinical inexperience. But do you ever feel that way?
Yes. Yeah. Yeah, I think you and I had that conversation privately about it a while ago. But yeah, in clinic, going to that initial conversation, yes, from feeling like am I the best person or a good person to be providing care to this patient if this is the first case on this thing that I'm seeing, why should I be the one to guide this care? That happens, but I would say it's become less so, that imposter syndrome in clinic remotely with opportunities with E3, prior with Barbell Medicine, these companies that I looked up to for literally years before grad school or during grad school, and now having the opportunity to work for y'all, that still occurs of how did I get into this position, and that imposter syndrome. And I don't really know that will go away until just time itself. But yeah, clinical work and remote work, it hits me like on a daily or weekly basis.
Do you feel like an imposter as the podcast host?
Yeah. I don't know how I got here, what's going on. Just kidding. Sometimes early on, but I think it's become a little bit more normal. And I also realize y'all asked me to do that because you entrusted me and I had experience doing my own thing. So I also, again, going back to that, like, was it luck or was it setting the foundation for these experiences or opportunities? And so just having that also realization of I'm in this position because of the prior opportunities, and then I can move forward and grow, and not have this like paralyzing imposter syndrome, but still have it in the back of my head at certain points.
Regarding any of the questions that we've discussed today or anything that we haven't discussed, do you have any advice for students or new grads?
The biggest advice would be just reaching out to people and creating friendships and networking and in relationships with people outside of your program in school or outside of your clinic. And I think one, just to hear and see a variety of perspectives, and then two, from an opportunity perspective down the road. And also, if you're in that position that I was in school, where I felt very nihilistic and frustrated and angry, seeking out other opinions or hearing other experiences, that would be definitely recommendation number one. If you're in school, trying to schedule your own clinical rotations to settings that you are confident or have just a higher chance of getting more out of than just having the school like blindly put you in a rotation would be a huge recommendation, because I know a lot of classmates that just took a rotation and had a horrible experience because they didn't do the due diligence to go above and beyond and like set them for themselves. Um, and then I would say like getting accustomed to just like being uncomfortable in rotations and as a new grad, because it's like an awkward experience, like interacting with humans and trying to stumble your way through uh, an interaction, through an evaluation and through a plan of care, and realizing that a lot of what you say and do you may cringe at like that day or that week or that, looking back. And so it's just like inevitable. So just coming to grips with that is also huge. And it like never feels good, but maybe just realizing it's going to happen, and hopefully just not becoming like super downtrodden and disheartened by it, but just knowing that it's part of the process.
Are you in a position? Do you feel like you're in a position where people can reach out to you the way that you reached out to others?
Yeah, I love chatting with people. And it's just, to me, that's like where I have the most, I don't know, refreshing conversations are with people that are just genuinely interested about other people. So if anyone wants to talk about their experiences in school or as a new grad, or they want to vent, I'm all ears. So I would love to chat with anyone and provide some perspective, or just listen if someone wants that or needs that.
Great. And they can, hey, leave it in the YouTube comments too. This was a great episode. I want to chat with Chris. Can't wait to learn more from him.
Boom.
Chris, any takebacks, apologies, giveaways?
Mm,
We're wrapping it up.
that's all I got. I don't have any apologies or take backs or giveaways.
All
Do
right.
you?
Hey, no.
Okay.
Uh, leave us some reviews. Leave us some comments. Tell us what you want to talk about. Someone asked me this a similar question on Instagram Q&A, and that kind of like gave me this idea of doing this episode. So we line up guests, but if you want us to talk about a topic or talk to a certain person, let us know. We always appreciate input.
100%.
But otherwise, Chris, thanks for your time on this lovely Saturday morning.
Thanks, Marc.